Discussing and we are going to treat very nice and unusual cases. This is a neurosurgical group and this is the vascular group. I am Dr. Gib Sharifi, Dr. Sohail Naderi is neurointervention, neurosurgeon, and Dr. Sajjad Khamawazadeh, neurointervention, neurosurgeon. We are dealing with a very nice case that referred to us by a group of neurologists that working on chronic headache. The patient suffered from a severe headache from 9 months ago, and she evaluated and treated for any other possible and reasonable kind of the headache. And after more and more evaluation, the neurologist group reached to the idea that the patient may suffer from intracranial hypotension. Intracranial hypotension means that we have a loss of CSF through an unknown and mysterious defect. Usually in the spinal cord, I have had around 5 patients during past 25 years. I remember so what a challenge that we had to prove this and treat them. Today, we encountered by idea with one of my colleagues. The doctor said to me that there is a possibility that CSF can drain to a vein of epidural. I cannot believe this because there is no histological proof over that or functional radiologic test to show this fistula. It is very mysterious, but we found the patient, and Dr. Khamawazadeh will say about the diagnosis history of this patient and what we have at now in our hands to decide over the further treatment methods.
Yeah. She's a 34 years old with chronic headache. As Dr. Sharifi said, she has underwent multiple diagnostic evaluations, including CT myelography 3 times and MR myelography and brain MRI with and without contrast. The results at first MRI and CT myelography revealed that there is suspicious CSF collection at the lower cervical and upper thoracic levels. At brain MRI with contrast, as you see, we can see rounding of sagittal sinus, enhancement of leptomeningeal, and slit brain ventricles, suggestive of intracranial hypotension, which is conclusive with patient his physical examination, orthostasis, and dizziness and vertigo at upright position. At the last CT myelography revealed there is leakage from C3 to T4. And then the physician referred to Dr. Sharifi, diagnosis of intracranial hypotension and making the tests for revealing the exact site of CSF leakage. At the last CT angiography, we could detect a spinal cord suspicious herniation and site of fistula at lower T3 level.
This is MR
myelography, which was not conclusive, and then patient underwent CT myelography at 4 positions, and the last image, this is the cord suspicious cord herniation and maybe the site of CSF leakage.
And this is the view that in the late phase we took the patient in supine position. It's very important in CT myelo to perform in both supine and prone position. Almost always you should do this because of many tricks that this is not the scope of this talk to speak about them. This defect, maybe it is a spinal cord herniation, but if it is spinal cord herniation, why we don't see this in MRI? Because MRI better showing us the spinal cord boundary, and it is a question why we didn't see this in MRI. And this is a very clear anatomical contiguity between the vein wall and the CSF pathway, but we cannot prove it. Because everywhere in the spinal cord, when you dissect, you reach the epidural vein. When you remove the cortex, there is a vein venous. Therefore, presence of some things cannot prove that there is a disease about this. But today, we want to do a myelography again by the suggestion of Dr. Nadiri, and during this myelography we do a fluoroscope, and also we do angiography with arterial and a venous together. And therefore, by say the procedure that we want to do.
The procedure that we perform depends mainly on the identification of the level of the fistula, depending on...
Clearly, this is T3. Clearly, because we have obsession to find it exactly, and
Yes.
this is posterior wall of T3.
So if it's proven that it's C3, then depending on whether it's positioned on the right side or the left side, the T3 vein drains into the superior intercostal vein, which drains into either left or right brachiocephalic vein. So then if it's on the lower levels, then we have to either catheterize the azygos or accessory azygos or hemiazygos vein. But for the T3 level, we will go through the brachiocephalic vein, and then we will enter the superior intercostal vein. Then we can identify the T3 vein, and then we will inject onyx, we will make a cast, and then we will penetrate into the foraminal vein, which is one of the veins consisting the Baxton plexus. And then when we make a good cast, we will enter the CSF pouch there, and then when we block it, that's the good result, and we'll satisfy it.
And what will go to the CSF pouch?
The cast of onyx. The cast of onyx will penetrate.
Supposedly it will happen.
Yes.
We cannot show that. Therefore, we will go and make a cast around the Baxton plexus of T3 by finding the draining vein and going there and making a cast around it. This cast of the venous, for example, conglomeration of some things may make inflammation, and this inflammation will seize the defect. It's my theory.
That's
Because if on the venography we can show that the dye comes into CSF, we can prove that there is a connection. But if there is no connection, it will make a role like a blood patch. A blood patch, what do some things? Blood patch makes inflammation, and inflammation makes occlusion and the defects. Therefore, I will propose that this way of treating this disease is a kind of more selective blood patch. Nothing than fistula, because when I introduced by Dr. Khambaba by this disease, I have a marvelous feelings that I found something new. But I don't have this. I get the idea what will happen. Therefore, we will say that by injecting the onyx inside the regional vein, we make a more precise blood patch to have a more precise inflammation and the side effect, and we can close it more precisely. I think that this is the way. What we should do today, these two guys are very expert in the neuroscalar things, and I am happy to see what will happen.